All right, welcome back everyone. We're going to do part 2 of communicable diseases. In the first part, we talked about these general concepts of the burden and understanding how much infectious or communicable diseases do contribute to overall burden in terms of mortality, disability adjusted life years, the various routes of transmission, airborne, bloodborne, vector-borne, and then how we identify the cause, so those Cope's postulates, being able to identify the organism, and the potential impact. And so the transmissibility of an agent and the severity of the illness that it causes together are going to determine the potential impact on your population or community. And now that I've graded some of your earlier assignments, I just wanted to use the example of Barron County versus Dunn County to illustrate the potential impact. So first of all, when you looked at the incidence rates of cases, hospitalizations, and deaths in Barron versus Dunn County, and you went to make a chart, if you just put it into a table and made a bar graph, you would end up with something like this, right? So you would see cases and you would be able to see that there's a difference there. And then hospitalizations in this chart, they look kind of the same. And deaths you can't really see at all, right? So we're dealing with the difficulty here of some very large numbers and then some much smaller numbers. So the hospitalizations and the deaths are so small that we really can't see how they compare to each other. One partial fix for that would be to put data labels, right? So data labels help a lot with conveying information so you can see the actual numbers, but still it does not powerfully and accurately convey the differences that you all saw when you calculated relative risk. So a much stronger submission for a way to show that information would be to do something like this, to put them on different axes, right? Because anytime you have the, let's see if I can get the right instrument here, right? The cases are up in the many thousands, and in order to have them not dwarf the hospitalizations and the deaths, you really need to put them on different axes. So here we can see quite clearly that Barron had a lower case incident rate than Dunn County did, but yet a significantly higher hospitalization rate and a much significantly higher death rate. So this approach to demonstrating the data, to visualizing the data for people, is much more effective at telling the story of the differences between Dunn and Barron County. And then I asked you to hypothesize as to what perhaps may have resulted in the fact that there were more hospitalizations and deaths in Barron County than there were in Dunn County. And many of you actually identified factors that are in fact true. So looking at the impact, right? So we're seeing more hospitalizations and deaths. Why? Well, is it severity or is it transmissibility? So in terms of transmissibility, for R naught, it's the pathogen itself, just how contagious a germ it tends to be, any mitigation measures that are in effect, and how much immunity is in the population, as well as what's the latent period. That's going to impact how quickly it can spread. Now, in terms of transmissibility, since the overall case numbers for Barron County were lower, then the transmissibility itself was probably about the same in the two counties because the case numbers weren't all that different from each other. But when we look at the severity, that's where we saw the difference, right? So the pathogen is the same. The exposure dose, probably the same, right? It's not like people in Barron County were purposefully coughing in each other's faces and people in Dunn County weren't. Underlying risk factors, right? So risk factors that are more common in your population than in the others. So when we talk about vulnerable populations, remember the very young, the very old, pregnant people, people with immune compromise, and people with certain medical conditions. And it just so happens that Barron County, oh no, this got cut off. Barron County has a significantly older population than Dunn County. Dunn County has so many young college students, so proportionally there are not as many older people in Dunn County as there are in Barron County. So in fact, in Barron County, about 24% of the population is age 65 and up. So that's almost a full quarter of their population is high risk. In Dunn County, it's about I think that's about 16, 17%. So a significant difference in the ages of the population. So the difference that we saw in the outcomes is due to difference in severity, primarily due to those underlying risk factors, that older age that we see in Barron County. Now, many of you also said, well, maybe Barron County has a lower vaccination rate, right? So less immunity. And in fact, during much of the pandemic, Barron County has had a lower vaccination rate. When I just looked today, it's pretty equivalent, actually. So who knows if they finally caught up, because they were seeing people getting severely ill. I know earlier in the pandemic, they did have lower vaccination rates, but now it's about equivalent. So there you have it. So potential impact played out right in front of you. Okay, so in this part 2, now we're going to talk about tools and then briefly about strategy. So what's our toolkit for communicable diseases? We talked about our toolkit for non-communicable diseases, and some of these are going to be the same, right? But some of them are going to be different. So they are barriers, vaccines, screening and case finding, and treatment and contact treatment. So those are the 4 main tools in our toolkit for communicable diseases. So we'll talk about barriers first. A barrier is any intervention that you do that decreases the risk of exposure to a communicable disease. It decreases the risk of exposure to the germ. Okay, so a barrier is decreasing the likelihood that you're going to come in contact with a germ. So it could be a physical barrier, like condoms, right, that protect you against chlamydia. It could be wearing gloves or masks. It could be other forms of PPE. PPE stands for personal protective equipment, which is, you see an extreme example of that in the upper part of the slide there. You know, those full body hazmat suits and everything. But even bed nets, as we see in the lower left here, can be really effective physical barriers at protecting people from vector-borne illnesses like malaria, which is transmitted by mosquitoes. So bed nets have made a huge impact in many countries that are impacted by malaria. And then there are environmental controls, right? So the physical barriers are things that you do to protect your individual person. Environmental controls are things that we do that make it safe for you to be out and walking around the world. So spacing and social distancing, which we all did quite a bit of in the beginning of COVID, was actually quite effective at reducing your risk of exposure. Isolating people who were sick and quarantining people who were exposed and perhaps were going to be sick or in the early stages of being sick also makes it safer for you to be out and about. Ventilation. We've learned a lot about how important ventilation is in controlling COVID and making sure that you have clean air coming through. Sanitation is more important for other diseases and conditions. You're going to watch some media assignments in this unit about that. Insecticides are a form of environmental controls, right? So killing the mosquitoes so it's safer for people to be out and about. And then hand washing. If everybody's hand washing, then you're less likely to spread things, particularly those that are fecal oral agents, like many illnesses that sometimes can be transmitted in food, which is again why we see all those signs and regulations why food workers are required to wash their hands. So all of these things can be very helpful. So sanitation projects, for example, which are one of those environmental controls, make a big difference. Many of you, when you talked about how public health is at work in your lives, you talked about the fact that we have great sewage systems so that our waste is carried away and treated and disposed of properly so that then it somehow doesn't get into our environment and make us sick, right? So that we aren't being exposed to those germs in our environment, unlike the people who live in a place that looks like the picture shown. And again, one of your media assignments is going to be about people who live in neighborhoods like this and how difficult it is to avoid coming into contact with germs if this is the environment in which you live. Another one of the assignments is about a disease called trachoma, which is transmitted because of certain places where they have lots and lots of flies. And they have lots and lots of flies because they don't have good sanitation. So there's garbage everywhere, there's sewage everywhere, and so there's lots of flies. And the flies get this bacteria on them called Chlamydia trachomatis. And then there's so many flies that the flies are constantly landing on people. And so in this picture, you see 2 young children with many flies on their face. Now, if you or I had a fly land on our face, we would wave it away, right? And so you wonder, well, why aren't they waving it away? Well, you know, a good friend of mine worked in the Peace Corps for a while, and she worked in an area where there were many, many flies like this. And she said to me, you just had to stop swatting them away, because as soon as you swatted them away, they would all land again. There are just so many flies. And so people just let them be on them, because otherwise they would be doing this constantly all the time, and you can't live like that, right? So you just adjust and you just get accustomed to flies landing on you. Now, the problem here is that those flies transmit disease, and the disease that they transmit is trachoma, which causes eye infections, and so you'll learn more about that in the media assignment. So obviously, having systems for sanitation and waste removal has a huge impact, right, on disease incidence. Hand washing is another environmental control, right? So I rely on, when I go to the hospital or the clinic, I rely on the fact that people are washing their hands in between patients. Thank you, Ignaz Semmelweis. Sorry, nobody listened to you at first, but we now know that hand washing works. So what we're looking at here in this chart is when they did a huge campaign to encourage healthcare workers in the hospital to wash their hands. Now, you wouldn't think that this would be a stretch, but actually, historically, they still weren't all that awesome at washing their hands. So this was in the 90s when there was a huge movement to say, come on, people, you really need to wash your hands before and after touching every patient. And so what we're looking at here in the green bars is the numbers of, or it's actually the rate of all the people admitted to the hospital, the rate of people who got some type of infection while they were in the hospital, right? So hospitals themselves are kind of a dangerous place. There's all kinds of germs there. And one of the things that can happen is that you can go in for one thing and end up getting an infection while you're in the hospital. So that green bar is showing us the rate of people that got an infection while they were in the hospital. And we saw a significant decrease in that thanks to hand washing campaigns. I did my medical training in the late 90s and early 2000s, and it was just during my residency, so it was in the year 2000, that they first installed sinks in the hallway in the hospital. So it used to be that if you were going to wash your hands, you had to go into the patient's bathroom, which was awkward and weird and not often hygienic. And so it just didn't work very well. So it was actually that recently in the early 2000s that they started installing more sinks in the hospitals to make it easier for us to wash our hands, and had the sensors so you didn't have to touch anything and all that, right? So these things are important. Another example, right, of barriers in terms of personal protective equipment or physical barriers. Well, actually, we have a few here. So we've got physical distancing. So again, this was a very early study in 2000 looking at rates of transmission under different circumstances. So this was with less than 3 feet of distancing, 12.8% of people got infected. This is with 3 feet or more of distancing, only 2.6% got infected, right? Face masks, 17.4% without, 3% with. Eye protection, which was really important for healthcare workers specifically, 16% without, 5% with. So you can see all of these interventions, all of these barriers helped reduce risk of exposure to the germ, but not any one of them is perfect. So we have to account for the fact that nothing is perfect, and we're never going to prevent transmission with one strategy only. So therefore, we need to layer them and do multiple things in order to try to decrease as much as possible the risk of exposure. So the Swiss cheese model is kind of the nice one. So if you think of, here we have our Swiss cheese, here's our germ trying to get through, and Swiss cheese has holes in it, right? It's not perfect. It's not going to keep the germ out all the time. So this germ is going to get through. Oh, and it got through that one. But then if you have enough layers of protection, eventually it's going to get stopped, right? So there's this this idea that by layering many different types of strategies, many different types of barriers, right, by doing distancing and masks, for example, you can have a greater impact on reducing somebody's risk of exposure. So barriers is tool number 1. Tool number 2 is immunizations or vaccinations. Those are the same thing. Again, like transmissibility, contagiousness, infectiousness is all the same thing. Immunizations and vaccinations, basically the same thing. Okay, so first let's talk about how they actually work. So the way immunization works, thank you, Edward Jenner, for getting this all started, is that you teach the immune system in advance how to fight a particular germ. And the way you do that is you purposefully give somebody either a piece of a germ or a weakened version of the germ so that their immune system can learn to recognize it and learn to fight it. And the reason why this is so important, this kind of head start advanced lesson, is because that process takes a couple of weeks for your immune system to really develop a full response to a germ. So if you aren't immunized or vaccinated and you're seeing a germ for the first time, it can take 2 weeks for your immune system to really get up and going and fight it effectively, by which time you might already be really sick or dead. So what we do is we use immunization to teach your immune system ahead of time so that then when the germ comes, when you do get exposed to it, your immune system knows exactly what to do, can attack it right away, and then you do much better. Right? So it's genius, and it works really, really well most of the time, which is awesome. So when it comes to our goals for immunization, we have different goals, right? There are several different things we can hope to achieve. We can hope to prevent infections entirely, right? That would be the dream, right? We'll just prevent you from ever getting this germ at all. Your body will be able to fight it off. You won't get sick at all. You won't be able to give it to other people, right? Preventing transmission. But that can be really tricky to do based on the germ. Some germs we're really good at doing this. We can really teach the immune system how to just nip it in the bud, and you don't ever get infected and you can't ever transmit it to somebody else. But there are a lot of germs, COVID being one of them, for which we really can't get any lasting good immunity against infection per se. But what we can still do is prevent severe illness and death, or significantly reduce the likelihood of severe illness and death. So, and that's still a really important goal, right? So I liken it, so a good kind of metaphor here is a bulletproof vest. So the bulletproof vest is not going to prevent a soldier from getting shot, right? They can still get shot. There's still lots of places in their body where they could get a wound, but it will significantly reduce their risk of death, right? It's going to significantly reduce their risk of having a severe injury. They have their helmet and their bulletproof vest. And so here we see a soldier who's showing us his bulletproof vest that saved his life. And I don't know if you can tell, but he has, some blood on his chin. He did get an injury. He still did get injured, but way less than he would have, right? So, so it's a really important goal to have, right? We'd like to prevent people from dying if we can, at least early deaths. And then another goal sometimes is to achieve herd immunity. And this is something that we have actually achieved for many infectious diseases, which is why you have maybe never heard of them or have never known anyone who got sick with them. So let me show you some examples of some success stories of vaccines in the United States. So here we are again looking at one of my favorite data websites, Our World in Data, looking at vaccine preventable diseases in the United States. So here we can see diphtheria, and before the vaccine, there were 158 cases per million per year, right? These are good statisticians. They're giving us rates adjusted for the population, right? And that was back in the 1930s and 40s. and we completely eliminated it, right? So it's down to 0. Like nobody gets diphtheria anymore. We completely eliminated this disease. It's an incredibly effective vaccine. It prevents infection, it prevents transmission, and then if you're not infected or transmitted, you can't die. So really awesome, right? So we completely eliminated diphtheria. Now, measles, we almost completely eliminated the infection. In fact, we pretty much did. There are still some cases that happen in the United States, but they're almost always in travelers who come from another country that doesn't have immunization rates like we do. Or most recently, we've been seeing in some communities who are kind of anti-vaccine, some communities of people which are unfortunately kind of growing, we're starting to see measles crop up again. So far, as of when this graphic was made, we still were not having any deaths in the United States due to measles, but we shall see. All right, so again, look at mumps. We've almost absolutely eradicated it. Pertussis, huge reduction. Polio, gone, right, from the United States. It's amazing. This is another type of polio, rubella, which is German measles. So huge, these are incredible success stories of vaccination, and the reason why you almost certainly have never had any of these infections. So this is another way to kind of look at that trajectory. This is a child with measles. I am older than you, but yet even in all my medical school training and years of clinical practice, I never saw a child diagnosed with measles. Why? Because I graduated from medical school here, right? We don't have measles in the United States anymore, right? Unless it's brought in generally from another country, or occasionally now we're starting to see it in people who don't get vaccinated. Now, not all diseases have we had such huge successes. So we're still seeing some huge successes here, right? And then look at pneumococcal disease. So this is a bacteria that causes pneumonia, hence the name. It can also cause some other infections. We have significantly reduced it, right, in terms of number of cases and in terms of number of deaths, but not anywhere near the level that we saw with some of the other ones. It's harder. It's a tougher one, tougher to achieve those goals. All right, so preventing infections and transmission at all and preventing severe illness and death are kind of our two main goals in terms of clinical outcomes. The other thing we try to do in terms of kind of creating a barrier in an environmental control is to get herd immunity. So let's see if this GIF works. So if nobody is vaccinated and somebody gets sick, the disease can easily spread to all those unvaccinated people. But if some people are vaccinated, the disease can still spread, but it might take a little bit longer. It might spread more slowly. But if we get most people vaccinated, then the disease can't spread at all, right? There are no vulnerable hosts for it to transmit through. So if you can get good immunity against infection and transmission, you can get herd immunity, right? And in the beginning of COVID, we were really hopeful because in the beginning, our vaccines were like 90 to 95% effective against infection and transmission. So we thought, oh my gosh, maybe we can get herd immunity, in which case one sick person can't spread it. And then therefore, if there's somebody here or there or over there who's vulnerable, couldn't get the vaccine, they'll be protected by the herd around them, right? But unfortunately, what happened with COVID is that high level of immunity to infection doesn't last. This shouldn't have been a surprise because it's like other germs that we don't get lasting immunity against infection. But at least we do get lasting immunity against severe infection, right? So we still have our bulletproof vest. We don't have a tank anymore, but we still have a bulletproof vest. Okay, so in order to get herd immunity, to protect people who are especially vulnerable or cannot be vaccinated, you need really, really high levels of vaccination, right? So anything below really high levels, there's holes in the boat. and the water can get in, right? So you need to have really, really high levels of vaccination in order to achieve herd immunity, which we have done for measles and all of those other diseases that I showed you for the most part, right? With some exceptions, some communities. You can actually calculate how much of the population you need to be vaccinated in order to reach herd immunity based on the R0, based on how contagious that particular disease is, right? So the threshold that is shown here in the percentage is how much effective immunity there needs to be, right? So no vaccine is 100%. So if you had 100% of people who got vaccinated and the vaccine was 80% effective, then your effective immunity is 80%. If you had 80% of people got vaccinated and the vaccine is 80% effective, then you have 70 or 64% of effective immunity. Do you kind of see what I mean there? So anyway, you can figure out what it is that you need. Now, for mumps and polio, right, the R0 is around 5, 6, 7. So the threshold to get good herd immunity is, 70 to 85%. Pertussis and measles, I'm going to show you, right? So their R0s are really high. Remember I talked about how contagious measles was? So the threshold is somewhere between 83 and 94%. It turns out that the vaccine against measles is 91% effective, right? So in order to keep us in that range for effective immunity, we need like 95 to 100% of people to be vaccinated to have herd immunity, right? So that is why that is one of the required vaccines to attend school. Now in the state of Wisconsin, you can, as you did on your scavenger hunt, hopefully you found this, you can get an exemption based on personal beliefs. But then that puts everybody else and our herd immunity potentially at risk, as we have seen in some communities, right? Pertussis is 81%, so it's harder to get to herd immunity for pertussis. We're not totally there. The other thing that we need to think about when we think about vaccinations and immunization as a tool in our toolkit is disparity. So vaccines tend to be expensive. They tend to require trained personnel to administer them. They tend to require refrigeration. They require needles and syringes and clean and new and different ones for every single patient. And so we see a lot of disparity in access to vaccines just because of the cost of them up front and then all of the things that are involved in the supply chains and in administering them thereafter. So we see that countries with a very low gross domestic product per capita, very low percentage of people who had had at least one dose at the time that this study was done. So this was as of July 2021. Okay, so in low resource countries, very few people had been vaccinated. In higher resource countries, we see a lot of variation, right? So, so we know now that it's just not the ability to get the vaccine, right? So look at United Kingdom up here, look at Iceland, they did an amazing job. Australia's way down here, United States is here. So we see a lot of differences, right? We'll come back to that in a moment, right? But remember, when we're thinking about getting vaccines out to populations, right, we've got to think about the supply and logistics. Is there refrigeration? Some of the COVID vaccines have to be kept in ultra cold freezers that like most clinics didn't have. And so there was all this other stuff that had to be figured out. But then of course, the roles of federal, state, and local agencies in doing incentive programs or federally, we made sure COVID vaccines would be free for people, right? So we used tax dollars because we felt that was really important to not have costs be a barrier. So there are all these different things that are going to go into it. But even if you make it easy for people to get vaccines, they still may choose not to, right? So there's where that communication and trust comes in. That did not go well with the COVID vaccine rollout for lots of reasons. So we see a lot of disparity in vaccine uptake even in our own state. So this is a map of Wisconsin, obviously, and the color here is telling you a higher percentage of vaccinated residents and lower percentages. So this particular graph is telling us the percentage of residents who have received not only the primary series, but also the updated booster, which is recommended for everyone because there's Omicron now. So please get the updated booster if you haven't already. And you will see as a state, we are doing quite poorly with only 18% of our population. Now, you can also see significant disparities. There are some places in Wisconsin that have lower than average vaccine uptake, and then other places such as Dane County, no surprise, that have much higher uptake, right? So in Dane County, 33% of people have had the booster. So we see this impact of culture. We see this impact of education level. There's probably an impact of certainly the university and the people who work at the university or go to school at the university, which is a big part of Dane County's population. So there are lots of different factors that go into vaccine uptake. And of course, right now in our country, crazily, your political affiliation has a big predictor in terms of your vaccine uptake. All right, so let's come back to kind of a global view right now. So this is global number of child deaths per year by cause. I need to get my glasses. All right, and first of all, can we just celebrate that from 1990 to 2017, the number of child deaths, and now I love these people, but they should have given us a rate. But anyway, the total number went down from almost 12 million to 6 million. That's amazing, right? Like we've halved the number of child mortality from 1990 to 2017. This is a huge success, and it's mostly a success of public health interventions. It's not so much healthcare and doctors' visits, it's public health interventions, okay? So let's focus in, and if you look, although we did, from kind of 6 million down to 4 million, right? And a sizable chunk of this are these other causes that are not vaccine preventable. These colored bars are the vaccine preventable illnesses. So look, we have almost completely eliminated measles. That's so cool. Same for tetanus, right? We still have a lot of acute respiratory infections because not all of them, we can't get good vaccines for all of them. Same with diarrheal illnesses, right? Especially if you live in a place with poor sanitation, diarrheal illnesses are going to be a real problem. But we've made huge successes. So this is an incredibly powerful tool in our toolkit. This is number 2. We had barriers, vaccines, right, against communicable diseases. So toolkit item number 3 is screening and case finding. So these are the ways that we figure out who has the infection, right? So we want to find people who are infected so that then hopefully we can make it so they can't infect other people. Right? So we're thinking about the health of the population. Of course, we want that individual themselves to not be sick, but from a public health standpoint, we don't want them to spread it around. So screening is the same thing that we talked about when we talked about non-communicable diseases. So screening is looking for disease in somebody who doesn't have symptoms, right? So going out and testing somebody, even if they feel fine. Let me turn that off. That's annoying. Okay. So the same conditions that we talked about in the last unit, right? It should be something that's relatively common, not a needle in a haystack. We want to have a really good test that doesn't put you at risk. And we want to be able to do something impactful with that result, right? We want to be able to do something different if we're going to do a screening program for it. We want to have a treatment if we're talking about an infectious disease. Case finding is then a way to find other infected people. So what we're going to do is if someone is found to be infected, say they test positive on a screening test, we're going to talk to them and find out who their close contacts are. Who do they live with? Who have they had sex with? Who do they work with? Depending on the type of germ and what its route of transmission is, to find out who else might be at risk of having been infected by them, or maybe they got infected from them, right? And we're going to do everything we can to maintain confidentiality and privacy. But this allows us to notify them, right? And say, hey, gosh, we think you should be tested for this thing or maybe treated for this thing because we've been exposed. Many of you maybe got some phone calls like that in the beginning with COVID if you were here on campus. We're going to quarantine people if necessary, those contacts, while we're waiting for their test results or to see if in fact they are infected. We're going to test people, we're going to treat them, right? So we're going to screen people to identify cases, And then we're going to do additional case finding to try to find the people in their orbit that may also be infected. An example would be a chlamydia screening. So public health agencies currently recommend chlamydia screening for all women under the age of 25 who are sexually active. The reason is it's highly prevalent in that age group, so about 5 to 7% of people, when you test them at one moment in time, will be positive for chlamydia, and that's because it often has no symptoms, right? So, and we have a super good test, a really accurate test for chlamydia. And in female-bodied people, it can be serious. It can cause infections of the uterus and fallopian tubes, which can go on to cause infertility over time. So we want to find it and treat it. We have good treatment available for it as well. We also are often going to screen male-bodied people under age 25, but the recommendation is not as strong. Now, everything is the same except that male-bodied people aren't at risk of serious complications to the same extent that people with uterus and fallopian tubes are. It can cause some scarring in the male reproductive tract, but not much. It doesn't usually lead to infertility, so the likelihood of it causing significant problems for them is lower. Most college health centers will screen, right? Because still the prevalence is really high, and we would like to nip this in the bud. So, chlamydia screening, and then we're going to find cases because of our screening, right? So anybody who gets diagnosed with chlamydia on a screening test are encouraged to notify their sexual partners and say, hey, I got diagnosed with this. You might have it too. You should get tested and treated. We're also going to report it to the health department. This is not to get you in trouble, but it's to give you additional tools. So what the health department can do is call that person and say, we have reason to believe that you have been exposed to chlamydia, without saying who from, right? And we recommend that you get tested and treated. And so this is a really nice mechanism. So if you want to stay anonymous, if you don't want to have to make that phone call and say, hey, guess what, Jake, I just tested positive for chlamydia, the health department will do it and maintain your privacy. Now, sometimes they'll be like, well, that's the only person I've been with in the last 6 months. Then they know it was you, but that might not be the case, right? So both screening and case finding by kind of interviewing and looking at close contacts are going to be tool number 3, right? To find people who have the infection. Tool number 4 then is treating people, right? So let's treat the infection and get it under control or get it eliminated. And we're going to treat people's contacts as well. So we're going to treat the cases, and that will either decrease or eliminate their ability to infect other people, which in the public health sphere we care about a lot. Now, this will work for some types of infections and not others, right? As you know, there's not a treatment for COVID that makes you all of a sudden not contagious to other people. I wish there were, right? But for strep throat, for example, right? If you've got strep throat, they give you penicillin. They're like, okay, after you've been on the medicine for 24 hours, you can go back to school because you're not really contagious to other people. We don't have something like that for COVID. Viruses are tough. We're also going to treat contacts if we have an effective treatment. So a lot of times we'll just give them the medication just in case and not wait for a test result, right? We're just going to treat them. Let me give you an example. Let's stick with chlamydia. So if somebody is diagnosed with chlamydia, we're going to treat them with antibiotics. Antibiotics are going to cure that infection just like antibiotics cure strep throat. It's going to be gone. We're going to have them not have sex for 7 days because it can take a little while for the antibiotic to clear the chlamydia from their system. And so we know that after 7 days, they're no longer contagious to others. And then any sexual partners that we identify that we think were at risk of getting this or having given this to our index case, the person that we diagnosed, we're going to encourage them to come in and get tested. And when they come in to get tested, either at a local clinic or at the health department, who will do it for free, right? Because we want to make sure that people get treated, we're going to go ahead and give them that antibiotic at the same time we test them. We're not going to wait for the test result because then a couple days might go by and then maybe we have trouble getting a hold of them and then we need to call them a prescription somewhere. So we're going to give them that medication right then and there, ideally if we can. If they can't come in for testing in the case of chlamydia, oftentimes what we'll do is we'll say, okay, well, as long as you're not allergic to this antibiotic, we're just going to call this in for you. And we're just going to treat you. We're going to assume that you have it. And this is called expedited partner therapy, and it's legal in many states in our country, although not all, right? Okay. So those are our 4 tools. So we're going to use barriers to reduce your risk of encountering the germ, of running into the germ, being exposed, immunization to help bump up your immunity, and hopefully prevent infection transmission, but at least prevent severe illness and death. We're going to do screening and case finding to find people who have the infection so that then we can treat them, and we can identify their close contacts who may also be infected and do that case finding and treat those contacts. So last part of this lecture is, what's our strategy? What's our overall goal? Is it elimination or control? Those are the 2 basic things we're going to be, trying to decide between: elimination versus control. Is this an infection that we can completely eradicate from our population, or are we just going to have to learn to live with it and keep it under check as best we can? When you're trying to figure out if elimination is an achievable goal, a reasonable strategy or not, there are several things that are going to influence if you're going to actually be able to eliminate a disease. So if there's an animal reservoir, it's going to be really hard. So when we talked about routes of infection, we talked about bats and rabies, for example. We can't treat all the bats for rabies, right? We can't ever eliminate it. So rabies is always going to be in the world, right? We can't eliminate rabies. Is it short-lived in the environment? So remember we talked about things that can be transmitted by fomites. They can live on inanimate objects and surfaces, right? If it can live on a surface for a really long period of time, like anthrax can do this, it's really hard to eliminate it. If there are long-term carriers, so these are people that have the infection or have the germ, they may not be sick, so they may actually have an infection, but they have the germ living in their bodies for a really long period of time. Mono is an illness caused by a virus where about 10% of people who ever get mono always, or intermittently at least, have the virus in their throats. And that is how it then gets spread to other people. They don't know that they still have it. They kiss somebody, share a drink with somebody, and that person gets mono. And they're like, I don't know how I got mono. I don't know anybody who has mono. It's like, well, you were close to somebody who is a carrier. So if you have carriers around, it's really hard to eliminate the disease because they're hard to find and treat. You want herd immunity to be possible. So you want your R0 to not be too high, or a vaccine that's really highly effective, like we have with measles. So with COVID, for example, the R0 now with Omicron is somewhere between 5 and 10. 10 is quite high. And our vaccine is not highly effective. It's somewhat effective. It's about 30 to 40% effective, but it's not highly effective against infection and transmission, not like it used to be, right? So then that kind of comes into this long-lasting immunity, either because of previous infection or because of vaccination. And what we know with COVID is that your immunity wears off over time. That's not a surprise to us. It does with other coronaviruses. No reason why this should be different. We were hopeful it would be different in the beginning, but it's no different. The condition should be easy to diagnose and identify. So to do that case finding and screening, right, you want to have a quick ability to pounce on it and be like, oh my gosh, you have this thing, let's get you treated. And so then we can eradicate it and prevent you from giving it to other people. And then you want to have some type of effective treatment or post-exposure vaccination that's available. So unfortunately with COVID, I'll stick with that example, the treatments that we have, a lot of them no longer work because the virus has mutated. We still have Paxlovid. It helps for sure, but it can't be used in everybody, and it's not it's not awesome. It's very helpful, but it's not going to significantly reduce your ability to infect other people. And we have no post-exposure vaccination. So there are some illnesses where you get exposed and we can give you a vaccine and that can significantly reduce your risk of disease. That doesn't work for COVID either. So again, let's kind of see how COVID stacks up. All right, for COVID-19, there's no animal reservoir, so that's good. I mean, we think it came from pangolins or something initially, but that doesn't seem, well, now I'm having second thoughts because cats and dogs have been getting COVID too. I may need to change that. It is short-lived in the environment. It doesn't live on surfaces for very long. There are not many long-term carriers. It's very rare for somebody to be a long-term carrier, best we can tell. We're still gathering evidence. It's still new. We shall see. It hasn't been with us long-term yet. I don't know. Is herd immunity possible? No. Right? It's too contagious. The vaccine is not highly effective enough against infection transmission. Is the immunity long-lasting, either from a previous infection or vaccine? No, it is not. We're going to need to get COVID shots every single year. Is it easy to diagnose? No, its symptoms are none sometimes, or just like any other common cold or flu other times. It is not easy to diagnose or identify. And do we have good treatments to make you not contagious to others? No, not really, right? So is elimination an effective strategy for COVID-19? No, right? So we're going to aim for control instead. So where are we with COVID, right? So what's happening? So unlike SARS-1, which was one of its cousins, and MERS, which is another cousin, so these are other viruses that are very similar to the SARS-CoV-2 virus, which is the virus that causes COVID-19. Those we actually eliminated really, really well because their R0 was 0.6. They were not very contagious, right? Omicron, we think the R0 is at least 5, if not higher. We can't. We don't have a good enough vaccine. Our bodies aren't able to mount effective enough immunity after either vaccine or a natural infection to last and prevent us from getting infected again. Not going to happen. So what's happening instead is that this pandemic is now shifting to become what's called an endemic. So it's a disease that's just going to be with us forever, pretty much, just like influenza is. Right? So it's going to be with us forever. And over time, as we do build up some improvements in our immunity, some improvements in vaccination, some improvements in our ability to treat it, right? It's going to become less severe. There's still going to be outbreaks, right? They're still going to come, but over time, they should become a little bit less frequent and less severe. It seems as though we're already starting to see that happen. But they're still going to regularly occur. And as the virus mutates, as it will, because that's what viruses do, right? We might have blips and bumps that come up again if it mutates in a way that makes it better able to escape our immunity, or it mutates in a way that makes it even more contagious, right? So we're going to be dealing with this for a while still. So our strategy is to control it, right? To limit the damage that it does. And vaccination is actually our best tool because vaccination is still highly effective, 70 to 90% effective in preventing hospitalization and death from COVID-19. So our best tool for controlling and learning to live with COVID-19 is going to be to try to encourage vaccination. And we really kind of blew it on that one. All right, but so that's what we're doing with COVID. Now, China tried for a zero COVID policy. China tried for an elimination strategy. And early on in the pandemic, there were reasons to think that would be possible, right? So early on, it was not as contagious. The R0 was lower. It was 2.5. Early on, the vaccines looked to be really effective at preventing infection and transmission, and they were. It just didn't last, right? So China really tried hard to do this zero COVID policy, and they were actually quite good at it for a long time. So I don't know if you remember the Beijing Winter Olympics, but the fact that they were able to have a Winter Olympics during a huge surge in COVID. They had all kinds of testing protocols and sanitizing and masks, and the fact that they were able to bring all these people together from all over the world, they did barrier measures, tool number 1, like crazy. There were so few cases associated with the Beijing Olympics. It was amazing. It was a masterpiece. It was just a beautifully done piece of public health, but it took a lot of work, right? And it took a lot of restrictions and a lot of barriers, right? They had to have a lot of measures in place. And over time, right? Adhering to very, very strict regulations for this entire population of a very large country is not sustainable. And so just in December and January of 2022, 2023, people in China started protesting all of the kind of lockdowns and the severe measures as China was trying to maintain the zero COVID policy. And so in early January 2023, the leader of China, Xi Jinping, said, okay, we're going to lift the restrictions, and it's a little crazy now because unfortunately, China has a relatively low vaccination rate. They also have a vaccine that's different than the ones we are using that is not highly effective. So they have all of a sudden gotten rid of their barriers. They don't have very good vaccines or vaccine coverage, tool number 2. In terms of case finding, they're no longer doing routine testing. And then in terms of treatment, right, there's no real treatment for COVID that decreases your infectivity to others. So in terms of the toolkit, right, they're getting rid of their barriers and their screening and contact tracing, and they don't have good vaccines. So, and they don't have natural immunity because a lot of people have never had COVID because they were under strict lockdowns, right? They did a lot of measures to prevent COVID infections at all. So what we're likely to see is some very high rates of severe illness, hospitalization, and death from COVID in China. It's tricky because, of course, they're not necessarily going to be very forthcoming with that data and that information because it's not going to reflect well on the leadership of the country. So it's about to be a difficult time for China. Right? But they tried elimination, but it can't work for COVID. It's just a germ for which that's not possible. All right, so this is the end of part 2 of communicable diseases. So we talked about our 4 tools that we have for combating communicable diseases, and then our choice of strategy, which is going to be dictated by the germ itself, right, and the nature of the germ itself, as well as what types of strategies are effective against it in terms of vaccines and treatments. All right, everybody, next is environmental health.